David Arun Kumar. He is the Dean and Principal of Hillside College of Physiotherapy and Allied Health Sciences, Bangalore. Head of Department, Vasavi Hospital, Bangalore. He is a Senior Consultant at Advanced Physiotherapy Center, Bangalore, and Chief Instructor at Advanced Physiotherapy Foundation.
Good afternoon, one and all. Thank you once again, Manipal Hospital and the organizing team, Dr. Ayappan sir and Dr. Gambir Raj for inviting me. I am Dr. David Arun Kumar. As you all know, I am going to speak about decision making in shoulder instabilities in a physiotherapist perspective. So we have very less time, 10 minutes. Let me see how much I can cover. Yeah, shoulder instabilities encompass subluxations, dislocations, and these shoulder instabilities pose a lot of significant challenge for a physiotherapist to rehabilitate or conservatively manage. And you all know from the morning we have been hearing about physiotherapists and the role of physiotherapists in shoulder managing either instability or rotator cuff or rotator cuff tear or pain or whatever it is, anything and everything about shoulder pathology without a physiotherapist you cannot manage. And by addressing patient specific factors and leveraging evidence based practices that we have, we can significantly contribute to a large amount in restoring shoulder function. Let's move on to understanding what is shoulder instability and what are shoulder instabilities. There are basically two types of shoulder instabilities. One is traumatic instability and the other one is in a larger way, in a vague way, it is traumatic and atraumatic, that is non-traumatic. See, traumatic, it's an acute one which is having a traumatic event preceding it, and atraumatic instabilities are those which develop gradually over a period of time with instabilities in multiple angles or multiple directions due to many reasons like ligament laxity, muscle weaknesses, or muscle movement patterning also. So there is something called as, I don't know how many of you have heard about it, Stanmore classification of shoulder instabilities. 2010, Jaggi and Lambert came up with this classification. According to them, this is basically for physiotherapists, how to classify instabilities in a physiotherapist perspective. He says, these two, Jaggi and Lambert says, the following, there has to be disturbances in either one or more areas in isolation or in together in these four areas. One is the capsulolabral complex and its proprioceptive system has to be disrupted, or the rotator cuff should be disrupted, or the surface arc or the area of contact between the glenoid and the humeral head should be hampered or disturbed, and there has to be, or either has to be or not be, central or peripheral nervous system disruption. So according to Stanmore classification, there is a triangle called a Stanmore triangle. In the triangle there are three poles in a triangle, and each has a different category of or a group of people whom you can categorize into. There are three poles, polar 1, that is type 1 structural instability where there is structural problem. The polar type 2 where you have atraumatic instability, that means there is no structural as such defects. And the last one is the polar type 3 where you have neurological dysfunctions wherein the movement patterns are mostly the contributory factor there. As you can all see the Stanmore triangle there, polar 1, 2 and 3, and there's two small arrows in between also showing the polar type 1 which can move towards type 2 and type 3, that is a traumatic structural instability can become an atraumatic structural one which can carry on like that if it's not addressed properly. And the polar type 1 also can move towards polar 3 by becoming a movement pattern impaired instability. So let's see what actually is this. Polar 1, the structural instability usually has positive apprehension test. We can all, I will show you the apprehension tests also in the next slides. Associated with rotator cuff weakness. And in that rotator cuff weakness, subscapularis is the most biggest culprit among all the other rotator cuff muscles. And in polar type 1, the patients or the group of people categorized under polar type 1 will not have global posture or single leg balance or the posterior kinetic chain disturbed. It will be undisturbed. They will have very good stability in that. And patients will slowly start showing signs of poor scapular control, abnormal muscle activation, altered trunk stability and balance over a period of time if not treated. This is polar type 1. And the polar type 2 is, again, there will be instability, positive anterior apprehension test with signs of capsular laxity, excessive external rotation and a sulcus sign, and also GIRD that we heard today morning in Padmanabh's class in the workshop, glenohumeral internal rotation deficit. And the abnormal translation, either anterior or posterior, in this atraumatic instability is a combination of multiple factors like excessive anterior capsular laxity, scapular dyskinesia, scapula is not moving properly, and tight posterior capsule. If you have a tight posterior capsule, the humerus slides anterior and there is anterior laxity, and muscular imbalances, and then sometimes congenital labral pathology also. And these signs usually varies among sports people based on the sport they play, as we heard in the morning in the workshop. Each athlete has a different set of signs that he exhibits in atraumatic instability. Then comes the last one, the polar type 3 neurological dysfunctional or muscle patterning type of instability. In this, a dynamic EMG has to show that there is an aberrant activation of latissimus dorsi, pectoralis major and anterior deltoid. These muscles are usually in tandem with other rotator cuff muscles, but in this kind of instability, these three muscles exhibit a lot of activation pattern whenever the person is moving his arm. That is an unstable arm, an unstable upper limb, and among the large muscles, and there will be suppression of all the other rotator cuff muscles except the infraspinatus in this group of polar type 3. And these kind of people, that is polar 3 type of unstable shoulder people, are the ones who will be party tricking their shoulders. Have anybody come across party tricking shoulders? Anyone here? Have you seen people dislocating and locating their shoulders? These are party tricking. They will be tricking their shoulders, showing off that they can, dislocate and anteriorly locate and, wing their scapulas. These kind of shoulders group of people are the people who actually fall into this category, wherein they will have muscle patterning or muscular laxity, muscular weakness, imbalances in rotator cuff, imbalances among the large muscles, and capsular laxity as well. So what is the impact of these shoulder instabilities on shoulder function? These are the impact that can happen in traumatic instabilities. It's a traumatic event which has happened. There will be sudden loss of shoulder stability. People will have difficulty or fear of moving their arm in some direction, and acute pain, limited range of motion, and there will definitely be a risk of recurrent dislocations. That is the impact on shoulder function. Atraumatic, there will be chronic instability. On and off it will be dislocating and relocating. Some people have an ability to relocate it and come to us. They usually don't come to a physiotherapist or go to an orthopedic surgeon. Oh my God, there's a lot to come now. They will have giving away sensations, and the people with atraumatic instability usually come to us only if there is pain. Okay, and this kind of set of instability usually occurs over a period of time, gradual onset, and there will be altered shoulder function. So patient related factors in decision making is age. Definitely younger people will will have higher demands. Older people, they prioritize on pain relief and simple simple normal activities of daily living. And if a person is highly active, you need to be aggressive treatment is needed, then you will decide what to do. Give me 2 more minutes extra, please. And the sedentary patients will always prioritize on pain management. And this is a anterior instability patient, wherein you have how you evaluate using positive anterior instability tests like apprehension and relocation test. This is how it looks. Patient's shoulder. And the posterior instability looks like this. The humeral head is slided backside. There is a dimple in front. And these patients will be positive for posterior apprehension test. And this is how a multi-directional instability looks. These are the ones who trick the shoulder. These are party triggers. See, the patient himself is translating it, and now you see the instability happening there. See, these are multi-directional instability. They will have positive apprehension test in anterior, posterior, and even in inferior also. You pull, you can see a sulcus sign. So stability will just move forward. There are 2 types of stability that a joint needs. One is capsular ligamentous and the other one is muscular tendinous, that is in anatomy. And there is a very important thing called as rotator cuff interval. These are the borders of rotator cuff, superior border, inferior apex and base. If the rotator cuff interval is larger, the person, by virtue of having a larger rotator cuff interval, can have a unstable shoulder. And these are the
last special tests for the shoulder tension test can, with one hand stabilizing the patient's
Can
scapula,
you hear this?
move her arm into 90 degrees of abduction and
This is the
externally rotate
positive
the
anterior
humerus. A positive
apprehension
test
test.
is a look of apprehension on the patient's face. The apprehension test can also be performed with the patient in the supine position and her arm abducted to 90 degrees. Externally rotate the humerus and monitor for a facial expression of apprehension. The relocation test is performed after a positive apprehension test by applying posterior pressure on the proximal humerus and noting the patient's sense of relief.
This is the relocation. You press it down and the patient feels better. And this
The
is
anterior
the release
release
test.
test for
same
anterior shoulder
position,
instability can be
supine,
performed with the patient in the same position
abduction,
as
external
for the
rotation.
relocation test.
You
A positive test is the patient's report of pain or a feeling of instability upon release of pressure from the proximal humerus.
this is
Now
another
we're
one.
going to do the posterior apprehension test or posterior load and shift. We're going to come in here. I'm going to have him in internal rotation and flexion. Okay, and I'm going to come in. I'm going to stabilize here. And I'm going to load, axial load, and then again, I'm going to try to push. Good, and relax.
This is called as posterior load and shift test. And multi-directional, we just saw how to do all these 3 tests. We can use it and see whether it is multi-directional. And the role of imaging, we know X-rays, MRIs and CTs give us how to make a decision if there is a structural deficit. Then these are the last 2 slides. Physiotherapy, why, when and what. Why physiotherapy? We all know from the morning we have been hearing why physiotherapy. Without physiotherapy, there is no shoulder rehab or shoulder management at all. So when physiotherapy, when the tests are positive, you can start physiotherapy. When it's a chronic instability, anterior or posterior, definitely. If it is a multidirectional, 100% physiotherapy. And then if the patient is apprehension about surgical management, it's not only anterior apprehension, posterior apprehension, patient apprehension also. Most of the people don't want to go into surgery. These people fall into physiotherapy category. And when to refer them to a surgeon is, if it's an acute trauma, please refer. If there is clear radiological signs of bony defect, bony Bankart, Hill Sachs, or glenoidal labrum tear, all these things. And if the patient is young, please refer them. If the patient is a promising athlete and you see that there is a need for surgery, please refer. And then if it's a recurrent dislocation despite rehabilitation or 6 months of rehab in vain, you do 6 months of rehab and the patient turns back and says there's a dislocation, please send them. And a non-compliant physiotherapy patient. And what we do, we have been hearing a lot, and we hear some more from Dr. Naveen next. That is, we give them patient re-education, patient education, postural re-education, stretching, motor control and strengthening exercises. And post-op physiotherapy after the post-op, after the Bankards or Hill-Sachs repair, surgical procedure. The post-op rehabilitation in a nutshell depends on surgical procedure, surgeon's protocol. Please have a good communication with the surgeon, speak to him and ask him what not to do, not what to do. What to do, you know many of the things. Ask him what not to do. You will give a clear-cut indication as to the tissue quality, and the mechanism of injury has to be taken into consideration, and concomitant injuries if there is any other injuries also along with dislocations, and the tissue quality we have been hearing a lot, and impairments noted at evaluation. Thank you very much.